All right, so now we're moving on to the topic of congestive heart failure. Massive topic, obviously a very prominent topic in step one and an even more prominent topic in CK because of the clinical relevance of congestive heart failure. It's a very common scenario, happens all the time, and it's really, really common in America given obesity, hypertension, diabetes, the whole metabolic syndrome of things being a big problem here in America. So it's basically a clinical syndrome that leads to the heart not being able to pump enough blood. And there's multiple variations. So on the right side, you can see when you talk about heart failure, you got to figure it out. Like, is it right-sided cor pulmonale or is it left-sided heart failure? Is it systolic heart failure with a reduced ejection fraction because it's unable to actually contract? Or is it a non-systolic heart failure with preserved ejection fraction where it's unable to fill because it's just too beefy, right? Is it compensated or is it decompensated heart failure? Whole list of things to figure out. And heart failure is related to a bunch of other organs. Obviously, you can understand that since the heart is the one that's going to be sending blood to everything, when it starts failing, everything starts failing. And at the same time, when it starts failing, everyone else tries to do what they can to make it work better and to keep it functioning. The heart even tries itself to keep it functioning, but it doesn't really quite work out that well. Now, the American Heart Association and the American College of Cardiology, they have many guidelines on how to manage things. The New York Heart Association also includes a long list of functional severity and figuring out what level heart failure it is. With the New York Heart Association and all these other organizations, all of this is in first aid basically, and it's in many other books. But with the New York Heart Association functional classification of congestive heart failure, mainly you're looking at class 3 and 4, where class 3 you're going to have a little bit of limitation of activity, but they're comfortable when they're resting. And then class 4, where any physical activity, whether it's just walking a little bit or trying to get out of bed, will lead to symptoms of palpitation and dyspnea even at rest, right? So these are some variations that you're going to see. So here you can see the difference between the two as I was talking about, right? Systolic and non-systolic or diastolic, right? Two different types of heart failure. And these charts are critical because in step one, you're actually going to get these charts. And in CK, you're going to get conversation or questions related to these charts. Other questions are going to be up and down arrows related to a lot of the vocabulary that was from step one, like how does preload change? How does afterload change? How does vascular resistance change? And so on. So you really have to figure out what is happening when it comes to these scenarios. So over here, I've written left-sided heart failure leads to pulmonary edema and hypoxia. Obviously, if your left heart is not working, then blood is going to back up into the lungs. Inability to pump blood to organs causes blood to back up to the lungs. Patients get orthopnea and paroxysmal nocturnal dyspnea. Because of this, patients are unable to actually lie flat in bed. So what you'll often see is that the patient is going to be kind of using multiple pillows to sleep correctly, right? The pulmonary edema also ends up causing the same kind of issue in these patients. And generally speaking, you're really going to need this patient to not sleep flat because they're going to just wake up with too much fluid in their lungs and being breathless and stuff like that. So these symptoms are the mainstay of left heart failure. There's low left ventricular contractility, which causes two main issues: pulmonary venous congestion and a low cardiac output. The low cardiac output leads to a rise in the renin-angiotensin-aldosterone systems, which you need to understand going to renal. Heavily discussed in step one is the ROS system, where anytime there's hypoperfusion, not enough blood coming to the kidney then releases or at least triggers a release of multiple things, and you have the entire system of renin, angiotensin, and aldosterone coming into action to try and help, right? There's also going to be more sympathetic activity. If you have low cardiac output, the sympathetic nervous system is going to try to do what it can to really fix things as best as possible, right? So with your renin, angiotensin, aldosterone system being activated by the sympathetic activity also, ROS is the main thing that's going to try to, compensate for the difficulties occurring with heart failure. Keep in mind from step one pharmacology that there is activation of renin, angiotensin, aldosterone system is a sympathetic thing. In fact, let me just confirm this before I say it, I believe it was beta 2. But let me go back to pharmacology, autonomic drugs. And if we look at the various receptors and what they do, beta 1 actually. Yeah, there you go. So beta 1 is related to increased heart rate, increased contractility, increased renin release, and increased lipolysis, right? Which often is a big problem with beta 1 related medications. So, in patients with congestive heart failure, sympathetic activity is going to be one of the other things that's going to try to increase ROS. Now, ROS is going to lead to more sodium reabsorption, right, aldosterone, and that increased sodium reabsorption is actually going to increase systemic venous pressure. This will then, of course, lead to retention of fluid because you're retaining salt, so you get peripheral edema in these patients. But ultimately, the goal here is to increase preload, which would then try to increase cardiac output. Once all of this is done, once this, ROS, sympathetic activity, renal sodium retention, water retention, all of this is being finished, and you've kind of normalized cardiac output, this is when you call it compensated heart failure, okay? While it's still happening, is decompensated heart failure. In decompensated heart failure patients, you can also tell from the chest x-ray, you're going to see bilateral airspace opacities, blunting of the costophrenic angles due to pleural effusions, and a fissure sign often in chest x-rays as well because of the fluid trap between lobes. But once you have this compensatory mechanism kicking in, the pulmonary edema often is lower and cardiac output is better and blood is not backing up into the lungs anymore. So that's one of the remodeling methods that your heart and your body tries to do in efforts of making the heart work. However, this ends up backfiring and things don't work out too well. You can't maintain sympathetic activity forever, and nor can you do ROS forever. So ultimately, all of this is going to stop working so well, and then the patient goes back to really just having worsening heart failure and really, really bad symptoms. A really nice question is one about this list of things that occur to try to fix things. So you could get a question about like a 63-year-old man coming into the emergency department due to dyspnea. They'll tell you that over the past several days, he experienced progressively worsening shortness of breath while walking his dog around the block, right? Or even trying to take the stairs up to his apartment to the second floor, not even too much. They'll tell you that he even has difficulty breathing while lying in bed last night or anytime he tries to fall asleep on his bed. So he was only able to fall asleep maybe after moving to something like a recliner where he wouldn't be lying down flat. They'll also maybe tell you some history that could key you in to the fact that this might be heart failure. They might tell you that he experienced MI a year ago and that he's not really taking his medications that well because he lives alone and doesn't really have anyone to take care of him. They'll give you his vitals, but the vitals are going to look pretty normal, nothing significant. And then they'll tell you the physical exam as always, and they might tell you that they hear bivascular lung crackles. They might see jugular venous distension, bilateral pitting lower extremity edema. They might even give you the chest x-ray showing pulmonary venous congestion. And then they'll ask you which of the following is most likely contributing to this patient's symptoms, right? And they'll have a list of things, some of them that are false, well, most of them, all of them, except for one, that are false things that don't really occur in heart failure patients, and then one that does occur to try to help. So obviously the patient we're looking at, because of all the symptoms we're seeing in this patient, this is decompensated heart failure. So something that must be contributing to his symptoms is increased sympathetic nervous system activity. That's one of the correct answer choices. The other things that can be correct answer choices are like increased renin activity, increased systemic venous pressure, right? All these are things that are occurring in decompensated heart failure in efforts of making it compensated, right? So the symptoms that this patient is having are suggestive of acute decompensated heart failure. Heart failure generally occurs when a structural or functional cardiac disorder impairs ventricular filling or ejection of blood, basically your stroke volume not working so well, leading to a reduced cardiac output and excessive ventricular filling pressures, right? So your ventricle is basically always going to be full of blood because it never actually contracted to send blood out. The reduced cardiac output is going to be detected initially as a drop in blood pressure, which then triggers compensatory neurohormonal stimulation directed at maintaining blood pressure and tissue perfusion. This compensatory mechanism is mediated mainly by sympathetic nervous system activity, stimulation of renin-angiotensin aldosterone system, and the release of ADH, antidiuretic hormone. These responses together improve cardiac output by increasing chronotropy and inotropy, expanding the extracellular fluid compartment, and promoting arterial and venous vasoconstriction, thereby causing more blood to go to the organs. Back in many of my old videos, but mainly in step 1, I talked about how vasoconstriction is a way to send blood out of blood vessels and send it to organs, right? Just imagine if your blood vessel is dilated, all the blood is staying in the blood vessel. When you constrict it, or when you take anything like a Colgate, take a toothpaste, when you squeeze it, you get the paste to come out, right? So when you constrict blood vessels, blood goes to the target organ. So vasoconstriction is going to help make sure that blood is reaching all the various organs that are hypoperfused. Now, these compensatory mechanisms are eventually going to kick in and succeed in normalizing cardiac output. However, there's a lot of adverse consequences, and this basically backfires at some point. The increased afterload, the increased vasoconstrictive blood pressure from excessive vasoconstriction will further impede cardiac output, leading to fatigue and weakness, and will also lead to excess fluid retention due to poor renal perfusion, because if you vasoconstrict, although you initially send blood from that blood vessel to the target organ, now you have a skinny lumen that can't take new blood to that organ. High renin activity and the whole RAS system will also increase fluid retention, contributing to peripheral edema and pulmonary congestion. Now you have a person who was compensated for a little bit, didn't really treat himself and get better, so now it really got bad. Heart failure with symptoms of circulatory overload is what's called congestive heart failure, right? So first you just have heart failure, it's decompensated, it compensates, then you still haven't treated it, so now it becomes congestive heart failure, where you have all this congestion, right? Peripheral edema, pulmonary congestion, all this fluid stuck inside of you because of the renin activity and the sympathetic nervous system activity trying to help you. It's all not working out, and the heart is failing, so now congestive heart failure takes place. The deleterious remodeling occurs secondary to hemodynamic stress and neurohormonal stimulation, but all of this leads to a downward spiral, and ultimately the patient needs help, right? You need to treat the patient. The patient isn't just going to get better by themselves. One of the key little tricky things is the aldosterone escape mechanism. So make sure you remember that in heart failure, one of the things that come out is ANP and BNP. And remember, those are your atrial natriuretic peptide, and then the B is the brain natriuretic peptide. These natriuretic peptides, what they do is exactly in the name, natriuresis. It causes sodium urination. So the aldosterone escape mechanism is basically the fact that in patients with heart failure, because of the high ANP, although aldosterone is supposed to retain sodium, the ANP is going to cause them to urinate sodium. So oftentimes patients with heart failure tend to have normal sodium levels. This ends up being a huge topic in many step 1 questions, as well as in CK questions and in your everyday real practice. If you have a patient with heart failure who actually has high sodium levels, that is indicative of really bad heart failure. Like their heart failure is so bad, they're not even making ANP anymore. So aldosterone is still working, the RAS system is still working, and they're still retaining a lot of sodium, and their condition is about to get extremely, extremely severe. So that's something you really want to watch out for. Sodium levels, of course, are very significant for many reasons for all kinds of case scenarios. But when it comes to heart failure, it's even more significant. So you want to make sure you really grasp that idea. All right. Another question you can see maybe something like maybe a 58-year-old person came into the physician, 58-year-old man comes to the physician. They might say they have a 5-day history of worsening shortness of breath and fatigue. Smoked a pack of cigarettes daily for 30 years, so that's pretty bad. Vitals are looking pretty normal. X-rays then shown, and that's where it gives it away. When you look at the X-ray, you're seeing somewhat of a butterfly pattern of just a lot of congestion. So then they ask you, what's the most likely cause of this patient's findings? Well, the only explanation could be left ventricular failure. This patient must have heart failure, right? So stuff like that. It's always pretty straightforward. Now, if you need help understanding X-rays and how to utilize those X-rays even more to really grasp heart failure, then, hit me up with an email, sign up for the courses, get all the videos, get all the books, all my main notes where I break down different types of X-rays in my annotated books. and it'll really help you see what you're supposed to gain from x-rays that you looked at. Um, but all in all, chest x-rays are pretty much a definitive way to really understand what's wrong with the patient, right, without having to think too much about it. When you see it, especially along with a question stem, it shouldn't be too bad. And then, of course, I mentioned the up and down arrows, right? So again, you could get the same 58-year-old patient comes in with severe chest pain that maybe began an hour ago. Patient is describing it as a pressure-like pain in the center of their chest. So now you're kind of thinking maybe it's an MI. The patient had nausea but no shortness of breath. Medical history is going to be really just only showing you the typical stuff like hypertension and diabetes, but diabetes controlled by diet. You looked at the vitals and the blood pressure is 94/62, so that's pretty hypotensive. Physical exam shows diaphoresis or sweating, and cardiac auscultation may reveal a normal S1 and S2 with no murmurs or extra heart sounds. Lungs are clear, so it's not exactly heart failure yet. And then, of course, they give you the ECG and they tell you there's ST elevation in 2,3 AVF and V4R. So you immediately know there is an inferior MI in that patient. Now they're going to ask you about the hemodynamic findings. What hemodynamic findings would you expect in this kind of a patient? Well, you would expect a high right ventricular preload and a low left ventricular preload and high systemic vascular resistance. How would you get this right? So the question is just about right ventricular preload, left ventricular preload, and then systemic vascular resistance. And of these three things, only the left ventricular preload will be low, but the right ventricular preload will be high and systemic vascular resistance will be high. So remember that 2,3 AVF is mainly related to the right coronary artery, which means that this is a right ventricular MI. This patient's severe pressure-like chest pain that they presented with, along with the ST elevations in 2,3 AVF, are a clear indication of inferior MI involving the right ventricle. The right-sided ECG would better confirm it if you could do one. Bradycardia in the setting of hypotension is also a sign of right ventricular MI because right ventricular MI often involves ischemic disruption of the AV node or even the SA node possibly. Right ventricular ischemia causes abrupt decrease in right ventricular contractility, so of course your right ventricular preload will be high. There's a lot of fluid, a lot of blood that's going to end up staying in the right ventricle. It's not going to get pumped out because the MI messed up the right ventricle's function. Increased pressure is then transmitted back to increase your right atrial pressure and the central venous pressure. So if this question also asked about another parameter, that other parameter could be the CVP, the RAP, both of which of course would be elevated, and the patient would have central venous dissension. Now, lesser blood is going to be pumped into the pulmonary circulation, so that means that lesser blood is actually going to make it to the left atrium, so you're going to have a low PCWP and a low left ventricular preload. Cardiac output is going to drop, and of course, anytime cardiac output drops, there's going to be a compensatory vasoconstriction to increase SVR and help maintain blood pressure, right? Remember that cardiac output equation. That equation was always going to help you figure out what's going to happen, right? So if one of the parameters goes down, the other has to go up to maintain cardiac output. Other than that, there's not much else to really evaluate in such questions. So the whole logical scenario of what's happening as one thing goes down is what you need to get comfortable at being able to explain, right? Like I just did. So if that didn't really click, you want to go ahead and utilize the power of YouTube and go back a little bit and listen to it again. It was all logical. Everything that happened to this patient, what's going to be high, what's going to be low, and why, was very logical. It wasn't something that requires an MD degree to really be able to break down. Besides the last part where, of course, if cardiac output drops, then there's compensatory vasoconstriction to increase blood pressure. Increase SVR to maintain blood pressure. So these up and down arrow questions are a very prominent thing. These test writers obviously understand that students get very intimidated when they see up and down arrows, and they utilize that to their benefit to mess things up for you. Now, right-sided heart failure is really a whole scenario of its own. Right-sided heart failure, the main issue is going to be that when the right ventricle is not working, just like in the question we just talked about, the scenario that I just discussed right now, when the right ventricle is not working, blood is not going to go to the left ventricle, right? So again, very logical. In right-sided heart failure or in a patient with the right-sided MI, inferior MI in the 2,3 AVF ST elevation, the right ventricle is not working, so blood is going to stay in the right ventricle, which means blood is going to stay in the right atrium. Everything's going to back up into the superior vena cava, And then you're going to see central venous dissension. So high central venous pressure, high right atrial pressure. Blood won't enter the lungs, so there's no pulmonary congestion in this case scenario, no pulmonary edema, and blood won't come from the lungs to the left ventricle. So now PCWP is low because blood isn't really going into the lungs. Cardiac output is low because blood never really made it to the left ventricle. And to manage things, to maintain the patient's blood pressure, SVR has to increase. Okay, blood pressure equals cardiac output times SVR. If cardiac output goes down, SVR can go up, and it'll maintain your blood pressure. So that's something you want to make sure you keep in mind when it comes to questions and when it just comes to scenarios in general. Left-sided heart failure is something related to the left heart not working, where we see the symptoms we see that we already discussed earlier. With the right-sided heart failure patients, the majority of symptoms are going to be related to blood backing up. So hepatomegaly occurs with the blood backing up towards the portal flow, jugular venous dissension, and of course peripheral edema with high venous pressure leading to fluid transudation. Right? A lot of transudate is going to be accumulating. The other topic of these two graphs, right, whether it's heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. So what you're seeing here, this is the normal case scenario, right? You have your left ventricular and systolic pressure here. Remember, pressure and volume. Generally speaking, it goes this way. This entire diagram with ABCD is something that's discussed in step 1, where from here to here you're increasing volume, and then pressure starts increasing, right? And then you reduced volume, then pressure reduces, and again the valves open, and you keep pumping blood in all the different directions that you're supposed to. Now, the curves here are the more significant thing, right? So the bottom curve is your compliance curve, and this curve up here is your basically your stroke volume kind of curve, your contractility curve. How well are you able to contract? Okay, so let's take a look at both scenarios. Both scenarios are in this graph over here. Both of the pathological scenarios are in the graph on the right. So first one we're going to look at is the solid line is still showing the normal, and then you have this dashed line over here. Right, so in this dashed one, you can immediately see that the stroke volume has decreased. Right, stroke volume is from left to right, and the stroke volume is the difference between the two parallel lines on the left and right, or the D and B lines, and stroke volumes decrease. What you're seeing in this case scenario, in the dashed line though, is that the contractility is the same as the original, right? Contractility is basically dictated by the slope of this line, and this dashed line and the solid line have the same contractility, right? But the other line that's supposed to be at the bottom, right? This is the normal one here. This is the normal one right here. And you can see that now the compliance curve is higher. So when the compliance curve is higher, it actually indicates that compliance has decreased, okay? So for whatever reason, the ventricle is unable to expand, right? That's what compliance is about, is unable to expand as you're adding blood. So heart failure with a preserved ejection fraction, where basically your ability to eject blood is good. Heart failure with preserved ejection fraction, the real problem is a diastolic issue, right? There's no compliance. You see the ventricles are so fat, right? So stiff and thick because they've hypertrophied so much that they're unable to really, make space for blood anymore. So you can see the left ventricle is really tiny now, right? Really, really tiny now. So of course, stroke volume is slightly decreased now because the amount of blood in here is low, but ejection fraction is normal because that's a fraction. So the amount of blood that came in was correctly, the fraction of amount of blood coming in and being pumped out is still good, right? So ejection fraction is good. The ratio of blood coming in and being pumped out is still good, but the stroke volume is low because the exact amount of blood coming in is lower. The other graph here, the skinnier one over here, obviously also has a reduced stroke volume. It's a thinner graph, right? What you're seeing here, though, is that the upper curve, this curve, which was the contractility curve, has a significantly lower slope. So contractility has decreased, but it shares the same compliance curve. So basically, it's still as compliant as the original was, all right? And you can see the original, again, original one is right here, using the bottom as its compliance. This reduced ejection fraction one has the same compliance. So compliance isn't the problem here. Here, the chambers are so stretched and thin that they're unable to contract anymore, right? They lost their muscular ability to really contract. So it's full of blood, but the blood is never really going to get pumped out very well into the aorta, right? So those are your two different types of heart failure that you can get. It really depends on what's happening. So with heart failure with reduced ejection fraction, right? Heart failure with reduced ejection fraction, which is basically your systolic heart failure. Core problem is reduced contractility because it's so stretched and thin. Ejection fraction is lower than 40%. There's a high left ventricular end diastolic volume, which means that when diastole is finished, the volume in here is super high, right? And that's because there's a high afterload. There's a high pressure to pump blood into, so it's unable to pump blood into that aorta. By the Frank-Starling law, compensation is via hypertrophy to raise preload. However, that doesn't work out too well for them. The eccentric dilated cardiomyopathy is going to occur with an S3 heart sound. Right? So there's going to be eccentric stretching, right? Eccentric placement of muscle fibers. This is obviously easily diagnosed with a transthoracic echo, where when you do echo of the transthoracic area, you're going to see this super dilated heart. Treat with LMNOP cocktail of medications. So the LMNOP each stand for a certain group of medications. L for loop diuretics to cause diuresis, morphine for pain, nitrates for vasodilation, O for oxygen, and P is for position. Position the patient upright, because if they're laying flat, they're going to have the orthopnea or nocturnal dyspnea, and they won't be able to sleep well. ACE inhibitors with loop diuretics are very critical here. You have to give the ACE inhibitors. Beta blockers help prevent remodeling, but avoid beta blockers if the patient is still decompensated, okay? And wait until the patient is euvolemic. Digoxin can help control dyspnea and reduce hospitalizations. Start the patient on daily aspirin and statin if the heart failure happened due to an MI. Now, advanced therapy is with sacubitril, valsartan, and ivermectin. Very important case to keep in mind. These medications are far less commonly used, but they're really significant. What are sacubitril, valsartan, and this neprilysin thing? So neprilysin is another medication you could use. It has LYS in it, so you can imagine it's something that lyses things. Neprilysin is a metalloprotease that cleaves ANP, but sacubitril will stop neprilysin. So that's why you give sacubitril. It'll stop neprilysin from actually cleaving ANP. And you need ANP, otherwise, remember, sodium levels are going to be high, and that's indicative of really, really, really bad heart failure. Nostereotide is actually a recombinant form of ANP, and ivermectin. It was one of the last medications discussed in step 1 cardiac pharmacology, first aid. Ivermectin reduces SA impulses if their pulse is over 70, and beta blockers are contraindicated in the patient. Right, so you can use ivermectin if a beta blocker is necessary, but don't use a beta blocker if it's contraindicated, such as in a patient who has decompensated heart failure. Remember that if a patient has decompensated heart failure, their sympathetic activity is really high, their renin-angiotensin activity is really high. If you start giving them beta blockers while they're still decompensated, you're really going to end up stopping their compensatory mechanisms, and that's going to end up causing their heart failure to immediately worsen. You might need a cardiac device if the ejection fraction is really low, or an LVAD if maximal medical therapy isn't helping, but these are like the last case scenarios where basically you're giving them a machine that'll keep their heart beating correctly. You want to avoid calcium channel blockers because they can worsen the edema and increase mortality. But if you ever get questions about things that decrease mortality, you have to understand that ACE inhibitors, beta blockers, spironolactone, nitrates, and ICDs can decrease mortality in systolic heart failure. Diuretics and digoxin don't affect mortality per se. They're more for symptomatic relief, right? So ACE inhibitors are extremely important. They're also renoprotective, so really good medication for patients. Non-systolic heart failure with the preserved ejection fraction is a diastolic heart failure where the heart is so big and thick you can't really add blood anymore. The core problem here is a reduced ventricular compliance, but systolic function is normal. The left ventricular end diastolic pressure is going to be very high. So basically at the end of diastole, there's a lot of pressure in here because it's all really tight. Digoxin and spironolactone aren't really that beneficial here. Patients usually have hypertension or scarring that cause hypertrophic or restrictive cardiomyopathy. In this case scenario, you have concentric thickening, which causes S4 heart sounds. Okay, so the type of thickening is really critical, right? In the systolic one with the thin ventricles, you have your eccentric dilated cardiomyopathy. Okay, And in non-systolic preserved ejection fraction heart failure, you have concentric hypertrophic cardiomyopathy, as you can see. Right? So this is hypertrophic, this is dilated cardiomyopathy, and we're going to see that when we get to cardiomyopathy in the next video. Treat basically with the same class of medications for the most part, and the patient should be fine. For right heart failure, we mainly discussed this already, talking about how when you have right heart failure, everything backs up to the venous system, and you have a different set of symptoms, as you can see right here. Right heart failure is common in patients with COPD or other chronic lung diseases like cystic fibrosis. Lung disease can cause pulmonary hypertension, which is the equivalent of the left side having aortic stenosis or just a patient having really bad hypertension. Hypertension backs up into the aorta and causes the left ventricle to not work too well, right? So on the right side, the equivalent of hypertension is pulmonary hypertension, where something is causing the right ventricle to have extreme difficulty in pumping blood into the lungs. Cor pulmonale is strictly right heart failure due to lung disease. Patients will have exertional syncope and angina. Echo will demonstrate pulmonary hypertension and right ventricular dilatation. Catheterization is the gold standard diagnosis and will show elevated filling pressures, low cardiac output, and pulmonary hypertension. If they have pulmonary hypertension, then you go ahead and utilize the treatments that are available for helping with pulmonary hypertension. The last kind of heart failure that is far less commonly discussed is high output heart failure. All right. So now high output heart failure, although not exactly a very commonly discussed topic, it is seen, and when it shows up, you want to make sure you understand it. It's related to specific scenarios, okay? So one, it could be related to morbid obesity, which of course in America very common. It could be related to Paget disease, right? So you're going to see a patient with bone problems and somehow having issues with their heart. It could be due to acquired AV fistula, such as from a gunshot wound or some kind of really bad trauma that might have caused arteries and veins to connect. It could be from a congenital AV malformation if the patient is really young. And generally speaking, high output heart failure is most directly related to anything that can cause an AV fistula, like Paget disease can cause AV fistulas as well. So AV fistulas, you have to imagine what's happening. If you have a bunch of arteries that are supposed to go to the heart, and then you have a bunch of veins that come out, something like a bunch of veins that go to the heart, and then blood that comes out into the arteries. That's two different systems. But if at any point artery and vein connects, now you essentially doubled the number of arteries you had and also doubled the number of veins you had. Everything became one, right? That's why it's called high output. So primary disturbance is going to be a decreased systemic vascular resistance because now you double the number of blood vessels you had. So systemic vascular resistance is going to decrease. There's more pathways for things to take. When systemic vascular resistance decreases, of course, directly related is that blood pressure equation, MAP is equal to CO times SVR. So if SVR goes down, cardiac output has to go up. Cardiac output going up is the reason why this is called high output heart failure. You double the number of arteries, right? So you have to put out more blood. Ultimately, on the right side, what's going to happen is you also double the number of veins, so your central venous pressure goes up. And since you double the number of or the amount of blood, going to the lungs, PCWP goes up. So everything goes up, and systemic vascular resistance goes down. That's your high output heart failure. Really big issue. Right? But everything at the end of the day starts off from this basic equation. All right. So that's basically heart failure in a nutshell. You want to make sure that you really grasp what's happening with the hemodynamics in heart failure, how patients present in the clinic, what you're actually looking for in these patients, and of course the medicinal aspect, what you're using to treat them, right? Chest X-rays, how they're supposed to look like, what you're supposed to look for in the chest X-ray, and generally speaking, you want to avoid falling for mistakes that are in questions that could be due to questions that are full of extra wording. For example, imagine you get a question about a 65-year-old man that comes in because of a 2-week history of episodic retrosternal chest pain, right? Shortness of breath and palpitations. The episodes maybe occur when he's going up or down the stairs or when he's trying to walk on his treadmill to get a little bit of exercise in, right? Kudos to him, 65 and still on the treadmill. Symptoms resolve when he stops walking, so that tells you that it's a kind of like a stable angina, if anything. They'll then go on to tell you that the previous evening he felt dizzy and weak during one of these episodes. He also reports he had a cold 2 weeks ago. He was diagnosed with type 2 diabetes 4 years ago, and he takes glyburide, right? But overall, he appears well. Everything I just said in this little previous evening, walking, felt dizzy, 2 weeks ago he had a cold, all of this is extra garbage information. In fact, telling you that he had a cold 2 weeks ago could actually throw you off guard, because you might start thinking that he has diastolic heart failure because of Coxsackie virus-induced cold that he had 2 weeks ago. But then they continue to tell you that his pulse is 62 and weak, respirations are fine, blood pressure is all right. Cardiovascular exam is maybe going to show you a late systolic ejection murmur. So a late ejection murmur is S4. And they'll tell you that his lungs are clear. What mechanism is the most likely cause of his current condition? What's happening to him? And of course, there's a bunch of answer choices that are going to be given, but one of the many possible good answer choices is that he has increased left ventricular oxygen demand. The narrowed opening area of the stenotic aortic valve he must have is causing his left ventricle to work a lot harder, and against the aortic stenosis, when the left ventricle has to work harder, it becomes more muscular and starts looking a lot like this one here. This is not dilated cardiomyopathy, this is hypertrophic cardiomyopathy, right? So our patient would have left ventricular hypertrophy, but if you start focusing on the fact that he had a cold 2 weeks ago, then you start leaning towards dilated cardiomyopathy, which throws you off into the wrong scenario. Right now, this patient is presenting with 10-day history of episodic stable angina. He's probably got some level of chest pain because he's unable to supply enough blood to his own heart. His aortic valve isn't opening. And the reason you would think of aortic stenosis is because he's 65. 65 and above is a giveaway. Natural aortic stenosis, everyone's going to have it. The reduction in cardiac output during exertion is what's really causing him to have these symptoms, and his syncope as well, because there's going to be lesser blood going to the brain. Remember the SAD mnemonic for aortic stenosis: syncope, angina, and dyspnea, right? So you really want to make sure you key in on things that are significant to the patient's initial presentation, and not really get thrown off guard by other things in the question. And another question I really want to kind of create is one that is related to sodium. Okay, so you can get a question about like a 75-year-old person, 75-year-old man coming into the ED for maybe a 5-day history of worsening dyspnea, orthopnea, lower leg swelling, right? So edema. He has a history of hypertension, hyperlipidemia, non-alcoholic fatty liver disease, and he had an MI 10 years ago. Current medications are a bunch of good things like metoprolol, lisinopril, spironolactone, and aspirin. He drinks 1 beer daily, and he has a 30-pack year smoking history. So a beer a day isn't really an alcoholic thing, so he's okay. But the 30-pack year smoking history, obviously very significant. He's allergic to sulfonamides, so now you have to be careful. Don't pick a medication that's a sulfamed. And on, glancing at his medications, he's not really on anything that's per se a sulfa drug. Physical exam is going to show you he has JVD, 3+ pitting edema in his legs. Vitals are all looking normal. Crackles are heard in both lung bases. The point of maximal impulse of the heart may be, dislocated towards the left of the midclavicular line and maybe around the 6 or 7 intercostal space. So that means that his heart is kind of shaped different now. Which of the following, or what additional finding in general, will be the most strongly associated with an increased mortality? Or basically, what finding would be strongly associated with increased severity? And the answer would be decreased serum sodium. Okay, so under normal conditions, ADH secretion is primarily under tight control of serum osmolality. However, in patients with congestive heart failure like this patient, non-osmotic stimuli for ADH secretion become more relevant, such as increased baroreceptor firing because of all the things that are going wrong in the patient with heart failure. So the increased baroreceptor firing can cause more ADH secretion. So now ADH secretion increases due to decrease in cardiac output, and the increased ADH can lead to increased reabsorption of free water, which in turn results in hyponatremia. A decrease in serum sodium is closely associated with a decrease in cardiac output in patients with heart failure. Right? Increased BNP, decreased heart rate variability, and decreased oxygen indicate a poor prognosis, okay? Whereas a high cardiac index, that's actually a good thing. Cardiac index is basically cardiac output, and if cardiac index is high, that's a good prognosis association right there. So keep in mind, if you're looking at sodium levels, well, if you're looking at a patient with heart failure, you really want to watch those sodium levels, okay? The aldosterone escape mechanism always kicks in, and you're going to have ADA secretion in these patients. You're going to have the renin-angiotensin aldosterone system kicking in, a bunch of things happening. If sodium levels start becoming too low or sodium levels are super high, both are significant. But the one thing that's related to increased mortality and increased severity of heart failure is decreased serum sodium. What you're imagining is there's so much ANP activity that he's losing all his sodium. And on top of that, there's high ADH activity, which unlike aldosterone, only retains water, right? Aldosterone retains water and sodium. So that is another scenario that kind of, brings everything back together about how sodium levels are significant, and a low sodium is going to tell you that this patient's heart failure is really, really bad. Okay. Make sure you also go back and kind of revise the various medications, the loop diuretics, the potassium-sparing diuretics, and all the diuretics, which are actually discussed in renal pharmacology for the most part. And keep in mind, as we move forward into our topic of cardiomyopathy, this color-coded segment right here, right? So hypertrophic has concentric layout of muscle fibers like this. So in here, you're having concentric layout of muscle fibers. So if you were to be able to draw that out, it's like adding multiple circles. So you're adding more and more circles until you become really, really small in the center, okay? That is your diastolic heart failure with the preserved ejection fraction, right? So you end up hearing an S4 in these patients. There's going to be a very hard S4, indicative of diastolic heart failure. Dilated cardiomyopathy, which is this one, I like to write dilates. Dilates is eccentric series. So this is eccentric muscle layout of muscle fibers. So eccentric means that you're laying them out in layers like this, and you're laying them out in such an interesting way that it's not really causing the center to lose its space. Okay. In fact, since they're all laid out like in such an interesting manner, they kind of get pulled apart more easily. So the heart is actually expanding, it's becoming much bigger, and you get this dilated or dilates cardiomyopathy, where your muscle fibers are all laid out in series, so it's an eccentric layout. You get an S3 heart sound in them, and that's indicative of systolic heart failure. So when we move on to our next video of cardiomyopathy, we'll talk about that in more depth, and we can start seeing even better the things that come out due to heart failure.